Stephanie Huff, and I'm recording the last acid-base concept lecture. This one's on respiratory alkalosis. So just an overview. Respiratory alkalosis is characterized by a pH of greater than 7.45 and a PaCO2 of less than 35. It's always caused by hyperventilation, which is usually fast respirations or overbreathing. This leads to carbon dioxide deficit. Looking at the pathophysiology and etiology, in acute respiratory alkalosis, the pH rises rapidly as the PaCO2 falls. The kidneys are unable to adapt rapidly to the changes in the pH. The bicarbonate levels will remain within normal limits. Anxiety-based hyperventilation is the most common cause of acute respiratory alkalosis. Your physiologic causes of hyperventilation include high fever, hypoxia, gram-negative bacteremia, thyrotoxicosis, which is your elevated thyroid. During anesthesia and mechanical ventilation, if the rate and tidal volume, which is the depth of the ventilation, is in excess. Your early salicylate intoxication, which is an aspirin overdose, encephalitis, and high progesterone levels in pregnancy directly will stimulate the respiratory system or center, which potentially leads to hyperventilation and respiratory alkalosis. So if hyperventilation continues, this becomes a chronic respiratory alkalosis state. The kidneys compensate by eliminating bicarbonate to restore the ratio of bicarbonate to carbonic acid. The bicarbonate level is lower than normal in chronic respiratory alkalosis, and the pH may be close to a normal range. Results of alkalosis increases the binding of extracellular calcium to albumin. This reduces ionized calcium levels. As a result of this extracellular calcium binding to albumin, the neuromuscular excitability increases, manifestations similar to hypocalcemia develop. Low carbon dioxide levels cause vasoconstriction of the cerebral vessels, and this increases neurologic manifestations of the disorder. Risk factors. Anxiety disorders with hyperventilation is the most common risk factor for respiratory alkalosis. In critically ill patients, mechanical ventilation can be a risk for respiratory alkalosis, and that's usually if the settings on the ventilator, the breaths per minute are set too high or the peak pressures are set too high to meet the client's needs. Manifestations are going to include lightheadedness, feeling of panic, and difficulty concentrating, supramoral and distal extremity paresthesia, which is a numbness and tingling sensation, tremors, positive Cheboksik sign, and positive Trousseau sign. They may also have tinnitus, sensation of chest tightness and palpitations, seizures, and loss of consciousness. ABGs, again, are going to show pH of greater than 7.5 and a PaCO2 of less than 35. In chronic hyperventilation, there is a compensatory decrease in serum bicarbonate to less than 24, and the pH may be to a near normal level. Looking at collaboration, management is going to focus on correcting the imbalance and treating the underlying cause. They need to be in a quiet, calm environment with low stimulation to reduce anxiety or panic. ABGs are done prior to any medications or oxygen therapy because you want to get a good baseline of where they started. Pharmacologic therapy, anti-anxiety agents, or sedatives can be used to help relieve anxiety and restore normal breathing patterns. Additional medications to correct underlying problems other than anxiety-induced hyperventilation may be needed. Looking at respiratory therapy, paper bags have historically been recommended to treat hyperventilation. but they have found that it can cause hypoxia. Using the paper bag does help to raise those COT levels, but can trigger a panic attack, which can cause hypoxia. Other diseases can mimic hyperventilation, like myocardial infarctions. Further hypoxia leads to further cellular damage. Best treatment is to teach breathing exercises and encouraging clients to take slow, regular breaths. Nursing process. The nursing care is focused on reducing anxiety through environmental manipulation to reduce stimuli and create a sense of peace. A restful environment will help clients breathe slowly and effectively. On their assessment, getting a health history, you want to see if they have a history of anxiety disorders, the triggering event for the hyperventilation onset, any mental health disorders, coping mechanisms that they use, and available support systems for the client. In their physical exam, you want to assess breath sounds, neurologic function, respiratory status, and cardiac status, as well as changes in level of consciousness. This is a list of your NANDA diagnosis for respiratory alkalosis. In planning, appropriate outcomes might include identifying and treating the underlying cause, restoring acid-base balance, manifesting normal respiratory rate and rhythm, maintaining safety, and maintaining appropriate fluid status. The usual cause of hyperventilation is psychological, so you need to identify the underlying cause. Your nursing interventions will include assessing the respiratory rate, depth, and ease, monitoring vital signs including their temperature, because the underlying cause could be fever or hypoxia. You also want to assess skin color, obtaining subjective assessment data leading to the current situation, involves current health and recent illnesses, medication use, and current manifestations. Alright, you want to reassure the client that this is not a heart attack and will resolve when breathing returns to normal. Your hyperventilation and respiratory alkalosis symptoms can include dyspnea, chest tightness or pain, and palpitations, which all can mimic a heart attack. And you want to instruct the client to maintain eye contact and breathe with the nurse to slow respirations, protect the client from injury. Hyperventilation can progress when the patient loses consciousness. Respirations, respiratory alkalosis and acid base will return to normal once we can get the patient breathing better. And also, a lot of times if the patient is not able to slow their respirations down, the body basically takes care of itself and causes the patient to lose consciousness or pass out, and the body will reset itself and fix the respirations. You also want to refer them for counseling for repeated episodes of hyperventilation or chronic anxiety disorders. Looking at the underlying cause of hyperventilation, discussing anxiety and stress management strategies, teaching the client how to identify a hyperventilation reaction, and teaching them how to provide self-care, basically slowing their respirations down, and when to seek medical interventions. Evaluation expected outcomes can include client experiences no subsequent episodes of hyperventilation. They describe strategies for coping with anxiety in the future. Family displays the ability to contribute to calming the client during times of anxiety, and the client and the family will participate in support groups. So this finishes up respiratory alkalosis and the acid base. And again, as always, let me know if you have questions and I will try to help clarify.